inquiry has paid as much attention to how it is that we get to new knowledge as it has with how it is that we can make knowledge have an impact in the real world. We did not start a program on the assumption that we had all the answers about nursing and now had to tell them to somebody else. It was that we could uncover opportunities to get to better care delivered by nurses as we made the case through rigorous evidence that nurses are central to delivering high-value, high-quality care.
That understanding, which nurses always had, is something that the INQRI program is trying to kind of move up to the next level, move it from intuition to evidence, basically.
I think the interdisciplinary nature of it is very important too. It's not just nurses studying nurses and patient outcomes, but it's our other partners in other disciplines, researchers from those disciplines, working with us to also give us their perspective on how we can best develop and conduct this rigorous research.
Preventing falls in hospitals is a team intervention. One of the big problems we found was that the communication in hospital settings can be variable. So we saw that nurses routinely do fall risk assessment in the hospital, but the degree to which they communicate the results of that assessment and the interventions that are needed for each particular patient to the patient and across all the team members was quite variable. And so by having these tools, what we were able to do is find a way to take that nursing fall risk assessment and put it in the workflow so it was available for the whole team.
Just wanted to talk to you a little bit about your fall risk in the hospital.
When we talked to patients and their family members who had fallen in the hospital, what they told us was that they were hearing from their nurses that they were at risk for falls, but they didn't really believe it because they didn't see themselves at risk and they weren't given reasons why they specifically were at risk. And so, again, using the same fall risk assessment, we generate a patient level of literacy single-page handout that tells that patient why they are at risk and what they can do with the team to prevent a fall while they're hospitalized. Even patients who are at low risk, if they have any risk factor present, we have an obligation as their care team to identify interventions to mitigate that risk. And that's what our toolkit did, is it did that automatically for them. That was the main change that came across the care team, is realizing that standard one-size-fits-all interventions don't work.
And separate. There you go. And cross his arms as those weights come down again. And repeat. That's it. 2, 3. Good. Keep that posture
In
tall.
the majority of Americans, let alone older Americans, people don't engage in enough physical activity. With older adults, it also involves function. And so seeing this and seeing what was going on first in rehab facilities and nursing homes and then in assisted living, as assisted living began to grow, I really came to notice that, oh my gosh, it's even worse in assisted living.
And point, side, back, together.
We're not here just to put your shoes on. We're here to help you maintain that ability yourself.
To the back and together.
The function-focused care approach is a perfect fit with nursing and actually where nursing is going today, because I believe it helps nurses to work at their full scope. We spend the most time with that individual, and time is what's needed here.
After we interviewed nurses and we got their descriptions of the kinds of things they do to identify errors, we then developed a little instrument that would help to measure that. And we went and we surveyed nurses on 82 medical surgical units across 14 hospitals. And we asked them about the frequency with which they engaged in these practices, and we also asked them about other things concerning their work environment. And what we found was that a constellation of 4 of these practices, the ones that we considered that were key interception practices, having a doctor rewrite a medication if they couldn't read the order properly, asking why is the patient receiving this medication and doing that critical thinking, independently going back to the physician's orders and the record at the beginning of their shift and making sure that the medications that were listed on their record matched what was in the patient record. So these kinds of practices that nurses engaged in were associated significantly with fewer medication errors that reached the patient across the 82 units.
So at all levels, the goal here has been to say, who is it we need to be bringing around the table today to help nurses position themselves for making an impact today? And I think that that's been one of the great joys of this program. Great minds, great scholars, multidisciplinary perspectives on big issues, bringing those individuals together with the people right from the beginning who are going to make decisions about how to use that knowledge. I think for nursing, it's been a great story, but most importantly, it's been an extraordinarily important story for the people that we serve.